organizers and my friend Murli for giving me a chance to be here with you. And it's always nice to see that there are some people not only interested in neuro-ophthalmology but also willing to come so early in the morning when the entire neuro system is rather dulled. So, especially if you had a late night yesterday. So, we'll talk about investigations and imaging. And actually, I changed my presentation a little because I thought imaging always gives a sense of neuroimaging and imaging of the brain, and which actually, of course, we as neuro-ophthalmologists must learn to interpret. But we are often always dependent upon the radiologist, and in the end it's always a joint decision of understanding what the imaging is showing, because they need the clinical input from us and we need the subtle signs, and with them we need to guide to see where we are going to look for the problems that we are searching for. So I'll tell you about a new form of imaging which thankfully is the realm of ophthalmologists in neuro-ophthalmology. But before that, we'll just talk about how to approach. So we've gone through unilateral, bilateral, and some of it is going to just summarize. So when you have a disc edema, the three things you are looking for, or essentially the caveat for unilateral optic nerve pathology, is that you look at the other eye. So if you have, whether you have a disc edema, you have subnormal vision, you have anything in this eye related to neuro-ophthalmology, the key investigation or the single investigation of choice is to understand what's happening in the other eye, whether there is disc edema in the other eye, so it's bilateral, whether it's normal in the other eye, so it's a unilateral disc edema, or else the other eye has optic atrophy, so showing that either there was no edema earlier and it's slowly gone into atrophy, or there was edema earlier in that eye also. So we've gone through a lot of bilateral causes, including papilledema, pseudopapilledemas. We've gone through unilateral disc edemas when the other eye is normal, so it could be hyperemic or pale, and essentially pale usually is ischemic optic neuropathies of various kinds, and hyperemic could be anything of these kinds. So this we have seen. So we'll start with an interesting case. This lady came to us, 30 years old, sudden gradual decrease of vision in the past 2 months, bilateral simultaneous, slow, headaches, severe visual deficit, no limitation, overweight, no other systemic problems. This is the fundus. You can see that it's almost atrophic. You can see a few hemorrhages here. So it was quite clear that this was almost an atrophic papilledema. Whether we want to do anything was actually the decision we wanted to take. This was the fluorescein angiography. So first, usually you don't need to do a fluorescein angiography. I mean, the diagnosis was sitter, but we did it just to see, is there any perfusion in the optic nerve head? The key was that, is there some function you could think of salvaging? The vision is hand movements. Are you going to intervene and just for your own ego? But the rest of the investigations were normal. The opening pressure was still high on full doses of acetazolamide. So we were giving up to 2 grams a day, and still the opening pressure was very high. Nothing else was important. So the other investigation was a VER. So is, again, your aim for any surgical intervention is, are you going to get anything out of this process? You're operating right next to the optic nerve. Are you going to get anything out of it? So the VER showing some waveforms there, but not so great. So the imaging comes in here. You can a lot of people have described ultrasounding as a process which can help us to see the amount of edema around, but the best one would be an MRI of the optic nerves or orbits with contrast, with fat suppression. So you can actually see the amount of fluid around. Helps you in diagnosis, helps you to know that there is fluid just behind the sclera where you're going to make the opening of the optic nerve sheath fenestration. The other things, of course, in IIH could be a normal MRI, could be an empty cella, or could be tortuous optic nerves along with the edema. So in this patient, we went ahead with optic nerve sheath fenestration, and she did improve significantly after that. So these are 3 images, which is the kind of patients that come to us with a preliminary diagnosis of papilledema. So look, there is no edema here. They look like edematous, but there is no edema. You can see the vessels so nicely over the disc. It's just a crowded disc, just a small disc, and everything is coming out from the center. Here you can see edema, you can see hemorrhages. The disc is lifted. Ideally, of course, you should see on 3D on a stereoscopic 90D examination. But you can see all these exudates, a few splinter hemorrhages here and there. And here again, there is a little bit of edema here. But you see these hemorrhages, these choroidal changes, they are very far away from the disc. This is not papilledema. This is great for hypertensive retinopathy. So you can see lesions on the retina which are removed from the disc, so they are not contiguous with the disc, and and these pathology is not because of a disc edema. So again, another case, a 40-year-old male, difficulty in near vision, occasional headaches. This was the fundus picture on both eyes. Sent as a patient of IIH, was extensively being investigated. So when you look at this disc, the classical thing you see that although the vessels are looking normal, but there is a lumpy, bumpy appearance, the margins are not so good. This is the investigation you can do. Of course, there's no need, but you can do an ultrasound. You can see here, these are optic nerve head drusen's that are there. Even on CT, you can pick up a very high reflectivity because of calcium in them. So the other investigation of choice would be an OCT, where you can see an edema here. So when you are confronted with a thought that is this true or pseudo disc edema, you can get an OCT. These are the lifted optic nerve head and the edema that is there on the side. So this is called a lazy reclining Y pattern. So a recumbent lazy Y pattern, you can see the edema here. These are the classical features. Optic disc drusen's, on the other hand, you see there is no edema here. So there's no lazy Y pattern of the separation of the RPE layer. The edema is here. The disc looks elevated here, but there is no fluid here. And you can see these empty spaces that are there. So this is because just behind the drusen, there are empty spaces there in the subretinal area. Again, you can see edema here. You can see this is that lazy Y pattern we were seeing. This was in papillitis. So some amount of edema that is there is in papillitis, but you see it's not going very far. It's not a Y, it's more like a V here. So these are the different things. The other thing that we are now recently doing is the angle formed between the RPE basement membrane in the peripapillary retina and that which is far away. So this is a normal RPE basement membrane angle, which is absolutely normal in these. And when you look at a papilledema patient, you can see this is the line coming, and this is right next to where the optic nerve head is. So this angle that you are seeing severely pushed back, this is severely pushed front. So this angle at the back is what you are seeing in papilledema. And even in papillitis, you will see this angle is there, but it's rather small. So we found this as a useful method of picking up papilledema. You can see this changes that is happening over time. So this is the edema here, push back as it gets okay, the angle comes back to absolutely normal. And the same thing is happening in papillitis also, or any condition that has disc edema. Again, this kind of a patient has been described just previously, but you can see that it's very important for you to do a complete fundus examination of these, and disc edema should always be dilated after you've seen the pupillary reflexes. And IIH, like I told you about this, and edema around the optic nerves and a tortuosity. And following this, our patient, which we started off with, improved after optic nerve fenestration, so much so that the vision was about 6/18 and a field was possible. You can see the improvement in VER also. So management is medical management unless it's progressing despite that, and then you plan for surgery. So I'll stop there, and I'll just invite you all for the Neuro-Ophthalmology Society conference on 30th November and 1st December at New Delhi. Thank you very much.